Good evening, everyone. My name is Lauren Guest. I am a Senior Clinical Affairs Manager with Teleflex, and I am so excited to welcome you all to our very first Barrigel webinar of 2025. The topic for tonight's webinar is Advanced Rectal Spacing Case Reviews, which will be led by Dr. Michael Greenberg. And for those of you who don't know Dr. Greenberg, he is a highly experienced radiation oncologist and clinical associate professor at the Sidney Kimmel Cancer Center, which is part of Jefferson Health in Philadelphia. Dr. Greenberg also holds the title of medical director of the MRI Linear Accelerator Program at Thomas Jefferson and has extensive experience in rectal spacing, having performed over 3,500 insertions. Just to give you a little bit idea of the format for this evening, Dr. Greenberg will present for about 30 minutes, followed by a Q&A session. So any questions that you have can be submitted either via the chat function or the Q&A function, whichever you prefer. And then all questions will be addressed following the presentation. But we have a lot of great content to get to, so without any further delay, I will hand it over to Dr. Greenberg.
Well, thank you very much, Lauren. It's really a pleasure to be here, and always exciting to partner with Barrigel and discuss some very interesting cases. So obviously, the information that we're going to present is from personal experience. I am a radiation oncologist at Jefferson, so Barrigel is hyaluronic acid, and it really serves to act as a barrier. It's biodegradable. I always tell patients it's about 98.5% water, and it's certainly administered by people who are experienced. It's really, if I would say one word, it's fun to use. It's really, it's very gratifying performing these procedures, and we'll talk a little bit about that as we go along. So today we're going to talk a little bit about the role of Barrigel's rectal spacer in salvage cases, reirradiation using Barrigel and how we can do this, extracapsular extension, and use of Barrigel in HDR brachytherapy cases. And yes, all of those things that you were not allowed to do with other spacers, you truly can do now, and with a lot of confidence, which is really great. Okay. So the role of Barrigel rectal spacer in salvage cases, so important. So management of locally recurrent prostate cancer after radiotherapy is controversial due to perceived high rates of severe GU and GI toxicity. So a third of all prostate cancer patients undergo radiation in general. And even though this is kind of an old definition, biochemical failure after radiotherapy is defined by PSA level of 2 above post-radiation nadir. Now we really proceed well below that. Lack of prospective trials evaluating optimal treatment options after definitive radiation really give us, we don't have a definitive way to treat it, but there's a lot of different options which have been looked at. So, for instance, salvage options, radical prostatectomy, cryotherapy, high-intensity focused ultrasound, HIFU, SBRT or stereotactic body radiation, and brachytherapy, all with pretty good results. I'm going to talk particularly about SBRT and brachytherapy, which are two that I'm familiar with as a radiation oncologist. So looking at a master meta-analysis, which examined 150 studies of local salvage therapies after radiation, endpoints relapse-free survival as defined by biochemical failure, radiologic failure, and initiation of androgen deprivation. Looking at severe GU toxicities, grade 3 or greater, severe GI toxicities, grade 3 or greater. So the salvage options include, again, salvage radical prostatectomy, which a lot of surgeons are really steering away from. Certainly, there are some that still do it, and I certainly respect it. Salvage HIFU, salvage cryo, salvage stereotactic, which we talked about, and salvage brachytherapy, both low dose rate and high dose rate. So look at the relapse-free survival. If you look all across all of the different types of treatment, I mean, you can see at 2 years and 5 years, it's pretty similar. Which this slide is courtesy of Dan Cam's a radiation oncologist at Inova Health, great radiation oncologist. And you can see it's really just similar across all lines. So when we look at that, we would say, okay, then how can we do this with the least amount of morbidity? So reirradiation has reasonable safety profile with salvage SBRT and HDR really standing out. As you can see there, looking at the severe GU toxicity, the p-value is statistically significant for GU toxicity and severe GI toxicity, which really means to me that probably one of the safer ways to provide salvage therapy for patients that really are going to survive a very, very long time. So consideration of salvage therapy for radio recurrent disease will increase. The efficacy appears similar. So then how do we try to minimize this toxicity? Well, Barrigel, rectal spacing and recurrence, and re-irradiation. You know, I first started looking at this with a different type of spacer, and I ran into a lot of issues with things like fistula because it was such a high pressure situation. But, you know, it's so gratifying to be able to do it with Barrigel because you really can shape it. It's very safe. And as I said, it's 98.5% water. And it really allows you to flow, to be able to shape it as you need. So let's talk a little bit. I always like to say in presentations, let's have some fun now and talk about some fun cases. This is a 61-year-old gentleman with recurrent T2B prostate cancer, PSA 7.1, and he was previously treated with a IMRT almost 80 gray in May 2021. His PSA did nadir down to about 0.3, and now it's 1.6, and he has a small nodule at the apex. So here you can see his PET scan, both in transverse and in sagittal imaging. Okay. So again, these slides are on an MRI linear accelerator. You do not need to treat these patients on an MR accelerator. I've done them as well on regular accelerators such as a TrueBeam. So here you can see right down at the apex, I was able to get the Barrigel in. You can see that bowing centrally at about 6 o'clock position as the mass pushes down on the spacer, but it definitely gave us a lot of space from the anterior rectal wall to the mass itself, and we still could do urethral sparing. And you can see, the other thing to point out is you can see how much you can get more cephalad towards the SVs. There's lots of room there. Okay. So we were running into this more and more. This is a 66-year-old gentleman. History of a Gleason grade 2 prostate cancer. PSA was 16.7. So he had IMRT with a brachy boost, no androgen deprivation in 2019. He had a pelvic nodal recurrence in 2021 and got treated on the outside and received androgen deprivation as well as abiraterone. And he presented to us with a new left seminal vesicle recurrence. So we're seeing this more and more. And, you know, the question looking at this, and a lot of docs would say, oh my gosh, you know, you had external beam, you've had hormonal therapy, you've had a seed implant. How the heck are you going to get spacer in? Isn't there going to be a lot of scarring? So let's proceed and I'll show you. So here you can see on the MRI that the in the SV segment just off the midline on the left side, a little harder to see on the sagittal imaging. Okay. And here is that spacer as you can see in the sagittal, and these are images on the actual MR Linac, at least a centimeter or more lift. As I said, there's a lot of room behind the seminal vesicles, and you can see, even though the patient had radiation, how much room we had there to lift them off the anterior rectal wall. It's almost like a balloon there, or a sphere. I can tell you it was very easy putting it in. The Barrigel flowed very easily. The other thing, which is kind of interesting, is you do not need to put the spacer in as if you're doing a de novo case. You really can just put it behind the area of recurrence with a little margin. So the case goes quicker, but it really flows very nicely, and it gives you the opportunity for excellent salvage with maximum protection. This is a 70-year-old gentleman, so here's that question. Can you put a spacer in, or can you radiate after cryo? So 70-year-old, status post-cryo in 2020, had a biochemical recurrence with a recent PSA of 4.1. So our plan was to treat him on an MR accelerator, and you can see here that we had a long remnant, and the question is, how can we get in after the cryotherapy? You know, are there going to be ulcers? Is it going to flow? And you can see it was outlined in kind of like turquoise, but we got very good spacing and lots of maximum depression of the anterior rectal wall with the spacer. And he got treated in 35 gray and 5 fractions over about 9 to 10 days, and it's done very well. And his PSA now is 0.2, doing very, very well. Okay. So this guy I love. He's such a nice man. He was one of our first patients. So 83-year-old gentleman. He had IMRT back in 2005. So when you think about that, we certainly weren't treating with the tight margins then that we treat now. Probably 7 millimeter margins posteriorly, maybe 5 millimeters. So he had a current PSA of 5.5. So he had transperineal biopsies, and he had Gleason group 3 and 3 cores. We didn't want to give him androgen deprivation. He's 83. He's very functional. So the plan was for radiation alone. So you can see there, we did the spacer. You can see the sagittal and see the transverse image, and you see the PET image of the initial nodule. How much lift we really got. It was extraordinary how much separation we got from the anterior rectal wall to the posterior portion of the capsule. And, you know, the other gratifying things is the patient, when they leave, and these were done under local, you don't get calls that the patient is having pain or discomfort like we used to get with other products. They're not feeling fullness. They don't know when it's there. They don't know when it's disappearing. So it's really very, very tolerable. And this patient, his last PSA on the slide, it was 0.48. It's now 0.3. So he's done wonderfully. Okay, next slide. So this is an 81-year-old gentleman who had IMRT to 75.6 grade 2005. PSA was 8.3. On recurrence, he had transperineal biopsies and was placed on single-agent Casodex. This is his PSMA PET scan, which was pretty dramatic. You can see the fiducials there from his previous radiation. And I mean, that's pretty extensive involvement with all biopsies positive. So, you know, the question going in is, you know, are you going to be able to get the spacer underneath this? And as you can see here on the sagittal image, we got very good lift. It flowed very well. And as you're doing these cases, as I said in the beginning, it's really fun because you can see as it shapes. You can, as you know, initially put the first needle in centrally, and then you can add a little bit on the right side and on the left side until you really get what you want, as long as you want or as short as you want. And again, this was done under local, you know, just a little Xanax and no pain medications. Patients didn't require it. And the patient's doing extremely well. Okay. So what about, as I said, we don't always need an MRI linear accelerator. You really don't need it. We happen to be blessed with one, and that's great. So this is a 73-year-old gentleman who had IMRT followed by salvage cryo in 2013, presented to us with a PSA of 4.95. Now, let me just tell you, this was a retired DEA agent. He carries a really big gun. So I wanted to make sure that I did I don't want this guy coming back to me, let's just say. So you can see he had recurrence in his SV remnant. This is after two different modalities, external beam as well as cryo. So obviously there's a concern. Will you be able to get the spacer in? So we always hear the question, well, can you see it? Can you see the spacer under CT? So this is actually right off the imaging on the machine. You can see how much room we got from the anterior rectal wall to the posterior portion of the seminal vesicles that are in red, and the spacers in turquoise. So we got a lot of room, because I said there's a lot of room back there. And we were able to treat him on a true beam. Again, we gave him 35 gray and 5 fractions, and he's out well over 2 years and definitely not a headache. Thank God. Next slide. So again, multiply recurrent prostate cancer and selective placement of the Barrigel. So this is a gentleman initially 73 years old, treated in 2003. He had a T3N0 prostate carcinoma, grade group 3. His PSA was less than 10. He had multiple biochemical recurrences and was treated with androgen deprivation. He was treated with adjuvant radiation of 64.8 gray and presented to us with a rising PSA. This is his PSMA PET scan. And you can see that subtle blush under the bladder neck on the right side. So, multiple treatments. He had androgen deprivation. So our plan basically was just to place it under the right side, which is outlined in right, and we got really good shaping, really good flow on that side, and excellent displacement from the rectal wall. We treated with a pretty tight margin, and he's doing very, very well. So this is really true sculpting with the Barrigel, which is really fun to sculpt with, and gave us very good lift to protect the anterior rectal wall, and he's doing really well. So what about extracapsular extension? Again, all these things with other products where they say, well, you can't do it with this, you can't do it with that because of certain situations. So here is a patient with extracapsular extension. So very often, a lot of my colleagues will say, well, you're probably not going to get it in, or, are you going to be able to get underneath the extracapsular extension and separate the rectum? And usually what I tell patients is we're going to start and we're going to see how much lift we can get of the capsule off the anterior rectal wall. Because what we're finding is that probably at least 30% of the time, the MRI overcalls because of extrinsic compression. So here, this gentleman, you can see the extracapsular extension. We're pretty low down in the prostate, mid-gland, going into the apex. Again, sagittal imaging, and here imaging in transverse. And the final slide is, this is the intra-op case during the procedure, looking at that, which is like, it's so much fun to look at that because you can see how much lift you got and how well and how symmetrical that was, and on how it looks lifting the capsule completely off of the anterior rectal wall of well better than a centimeter, probably 1.5 centimeters. Again, this was done under local. Here again, here's a gentleman with PET scan imaging, pretty low down in the prostate, near close to the apex, and you can see that extension. And looking at that, you certainly respectfully could say, it's into the rectum, or it's very close to the rectum. And, a lot of these imaging, particularly on PET scan that we depend on so much now, the tracer kind of leaks, so it definitely overcalls how much extension there is. Okay, next slide. So here's that patient, and very often we'll make different mounds. We'll bring it up in one area, and definitely under the apex, I like to build it up a little bit more, particularly where the recurrence was. And we easily were able to lift the prostate off the anterior rectal wall and treat this patient very well. The one thing to remember as well when you're doing this and you're worried about the rectal wall, it is the spacer is almost completely water, and Barrigel as another product is something that the colorectal surgeons use in the anal sphincter for continence, so it's very safe to use. So you really don't have to worry. There's no reported fistulas in the database. Okay, so extension to the anterior rectal wall. So this was a patient, as you can see, with something that looks pretty scary. You see the PET scan where it looks like it's into the rectal wall. But if you look kind of close here, you can see there probably is a fine line of separation there, and it's really more extrinsic compression. So going in, I told the patient, we're going to see if it lifts, and if it does, then we will proceed with putting the spacer in. So again, here's that case, and just pointing out the area of extrinsic compression. From apex to about mid-gland. Yeah. Okay, next slide. And here's the patient now coming down with the spacer in. You can really see it best on the imaging, with on the MR. There was some distortion because of his artifact, but we've got a good amount. To me, I feel like it's a successful case, even if we've spared 3/4 of the rectum. But here we really were able to displace it where the rectal doses were very low. No problems. There was no morbidity. The patient did not feel significant pressure on the rectum, no changes in bowel movements, and no problems whatsoever with grade 2, 3, or 4, or even 1 morbidity. And again, this is looking at the transverse images from the MR Linac with extrinsic compression on the anterior rectal wall. So obviously we see patients with T3B disease with extension to the seminal vesicles. And here on PET scan, you can see a patient who's pretty scary, very bulky seminal vesicle involvement on his PSMA PET scan. Okay. Next slide. And, as I said, there's so much room behind the seminal vesicles, and here you can see how it balloons out on the first slide on the sagittal, and on the transverse, it almost splays out the seminal vesicles. So you really can separate them from the anterior rectal wall. And here, low down in the apex, again, very good separation from the anterior rectal wall to the posterior capsule down by the apex of the prostate. So what about brachytherapy? I love doing brachytherapy. We do 1 to 2 cases a week, and I'll tell you, I am absolutely sold on using it with Barrigel. So there's 2 ways, obviously, whether you do these are high-risk patients. So the question would be is, do you do the boost first or do you do the boost after? And both are great. I do the boost after. I put the Barrigel in initially before the external beam, but either way is absolutely fine. We can take a look at some cases. So this is an intraoperative case, just looking at the spacer. This is pre-needles. So he had a pretty good pretty good separation, pretty good placement and, from the SVs down to the apex. Just a video to show the symmetry down. I like to bring it down below the apex. So the looking at analysis of the data has shown that if you can get over a centimeter or more by the apex of the prostate, that's where most of the morbidity is with the treatment. So here you can see the needles in, and so I like to use the Barrigel with the needles. It's great. It glides right through the Barrigel, the needles. You can get treatment to the capsule, and you can get right into the seminal vesicle. So you can see here that needle is well into the seminal vesicles, boosting those volumes. So it really guides you, and it helps to protect the rectum. And it's absolutely fine to put the needle right through the gel. Again, things you couldn't do with a balloon, things you definitely couldn't do with pegylated spacers. So it really is very helpful in brachy cases. And here's just another live image with needles in. You can see that bottom needle well into the seminal vesicle with maximum separation with that spacer, and definitely feel comfortable putting it through the Barrigel with no problem. Here's just looking at a little dosimetry, and you can see the 100% isodose line covering the gel. So there's a needle going through the gel. So it's great when the isodose line is going through the Barrigel and not through the rectum, and that's why we use it. So it's really a lot of fun to use with brachytherapy cases. Some people have asked, well, if you have the gel in before, do you run into problems with there's too much lift, so the pubic arch is an issue? I haven't run into those issues, but I mean, I can certainly understand and respect that could happen. So, which is why, it's you could certainly put the gel in at the time of the case. So sometimes what I've done is I've had patients referred from the outside, and they had previously had Barrigel spacer put in, and I wanted to add a little bit more. So before putting the needles in and doing any planning, I'll add a little more spacer to one side to get a little more lift if there's a little void, like on the right side or the left side of the rectum. And that works great. You're just putting a little bit more in, and gives you more protection. Okay. Well, that was a lot of information going through cases, but as I said, it's really fun to do, and I'm certainly open to many questions. I would love to hear. Everyone has so much experience. I'm sure that's on the line, your experience, and certainly take all questions.
All right. Thank you so much for going through all that, Dr. Greenberg. That was very informative, and I'm sure a lot of people on this call learned a lot from that presentation. We still have the chat and the Q&A open. It doesn't look like we have anything submitted just yet, but if there's any questions out there, any at all, feel free to submit them, and we'll make sure that they get answered. In the meantime, I do have a couple questions written down that I was hoping maybe you could speak to.
Sure.
The first one I have is, can you speak a little more about the technique you use when treating a radiation salvage patient with Barrigel? Are there ways to optimize the space even with the presence of fibrotic tissue and or scar tissue?
Right. So, first, it's important to have the PET scan and an MRI scan before, so you can really see where you want to definitively put the spacer. You can see how well the Barrigel shows up on transrectal ultrasound. So once you have your ultrasound in the rectum, and make sure you do a really good bowel prep. Usually I have the patients do 2 enemas, one at night and then one in the morning. Then nothing to eat or just liquids after that. If it's done under local, sometimes we do it under conscious sedation. Once that first needle is in, you can kind of get a sense of how the Barrigel is going to flow. And the needle itself can definitely break down soft adhesions. So once you're in, it's okay to raise the needle and bring it down a little bit and make sure you're not tethered to the rectal wall. And as well, start to see how the Barrigel is flowing. And you may find it's flowing to one side. And if you want to get it on the other side a little bit of the rectal wall, there's two ways to do that. One, under just plain old transverse imaging, you can really just slowly paint right side and left side to help with the flow to more define where you want that gel to go. The other thing you can do is you can put another needle in. So by leaving your first needle in, you can put a needle next to it, like 3 to 5 millimeters away. And what you do is on the second needle, and once you're in, you point towards the gel. You can feel you're in it, because I like to always tell people the needles almost have AI, which is the new term nowadays. So you can feel that the needle going into the gel, it just flows. And then you take the first needle out, and then you can start painting a little bit more, and you'll see under axial that you are painting the other side. So that's just one other way to be able to fill in areas that you want to fill in.
Okay, wonderful. Thank you. Another question I had is you did talk about that one patient who received another round of radiation after having apical recurrence. And can you talk a little bit about Barrigel's ability to create space at the apex? And do you have any tips for how to achieve that apical space?
Yeah, so I keep trying different things. And one of the things I've been doing now is starting at the lower third of the gland. So rather than going back in the beginning, what I used to do is go all the way to the base or the SVs with my first needle and work my way down. I found that you can really work caudal to cephalad by just starting in the lower third and then work your way up. And it helps to really paint the gel up the apex. The other thing you can do is we are trained basically to go bevel down, to push the rectum away. But one of the things I like to do is I like to bevel up and kind of paint the gel up the apex, almost to the penile bulb. It gives you a little bit more space in that area to get well above a centimeter. And then once you're in, you can, even if you see a very, very tight space, you can slowly open it by going caudal to cephalad, by slowly delivering the gel, and it does open up that space very nicely. And you'll feel that needle in the gel because it really just flows. It's much easier than feeling. You won't feel resistance.
Okay, wonderful. Thank you. Just a reminder to everybody on the call, the chat and the Q&A are still open. So this is your chance to ask Dr. Greenberg anything and everything that might be top of mind. But one last question that I had is, can you speak to your process of implanting Barrigel for HDR and how that differs, if at all, from SpaceOAR in HDR? I know you touched on that a little bit, but could you touch on it a little more?
So, okay, SpaceOAR and HDR. Well, one of the big things is obviously you can't put the needle through the SpaceOAR because it's hard. So that in itself is I would believe would be a problem, because if you want to get the needles maximally in the posterior capsule or just underneath it to bring the dose to the posterior portion of the capsule, the best way is to be able to have the needle in the top of the gel. So that would be a huge issue. And of course, you can't do it in the balloon because you'll blow up the balloon. So yeah, you would deflate it. So, which is why I feel that the Barrigel, because it is like water if you feel it. It's such a gelatinous soft material that it really lets you maximally get good displacement. And then again, many people do the gel and the HDR first, and that's great. It's absolutely fine to do that. They'll put the needles in and then put the gel in after because of, fear of the pubic symphysis. And that's okay. Some of the best people I know do it that way, and they do an absolutely great job.
Great. And we actually do have a question in the chat. So the question is, when doing LDR brachy, do you prefer placing the Barrigel before or after seeds?
Okay. I don't do LDR breaking. I'm just doing HDR. I will tell you that I've done a lot of LDR, probably 1,000 cases, but it was well before 2000. So it's been a very, very, very long time. However, I think that a lot of people that are doing LDR are probably doing the seeds and then putting the spacer in right after under the same anesthesia. I believe so. And there's some excellent docs like Peter Oreo at the Brigham who does a lot of LDR and with Barrigel. So I guess there's a lot of ways to skin a cat, and so you definitely can put it in after without a problem at all.
All right, thank you. Great question. Any other questions out there? Now's your time to ask Dr. Greenberg.
So I can let me just think of a couple of things that.
Sure.
So the question would be is what about if a patient has a spacer put in, like a pegylated spacer, and you see him and they've told him that it's in the rectal wall, so they want to wait 6 months until it dissolves, and then they're going to treat him. So if that patient decides to seek you out and as a second opinion, and you see him, is it safe to put another spacer in after you wait for that time? So I had a patient like that, and we did wait the 6 months. We got another MRI scan, and we didn't see the pegylated spacer. So we did go back, and we went and put Barrigel in. And I wasn't sure what to expect. I had heard that it's absolutely fine, and there really was no problems with scoring. We got very good displacement of the anterior rectal wall from the posterior capsule, and it flowed very nicely. The Barrigel just seems to find its way through a stricture or score, and we get really good lift. So that's one thing, and I guess the other thing which I had showed in my slides was that what if you have to do it again? So I had a patient recently who recurred in the left side of his capsule, previous IMRT in 2010. So we put spacer on the left side of the capsule and treated him. And 2 years later, he came back, which we just saw him with recurrence on the right side of the gland. So I went ahead and we took him again we used conscious sedation and put spacer in. There was still a little bit Barrigel left on the left side, but we did fill the right side again, and he really got good displacement, and we treating him selectively just to that side. So it gives you a lot more flexibility for salvage, as compared to committing these people to long-term androgen deprivation, which really can be very morbid.
Absolutely. All right, last call for questions. Did such a great job going through the slides, Dr. Greenberg, that you answered everybody's question. So if there is nothing else at the moment, I just first want to thank you, Dr. Greenberg, for taking the time to go through and educate us all. I also want to thank all of the audience members who took some time out of your evening to learn a little bit more about Barrigel and rectal spacers and how they can contribute to patient outcomes. I'm sure there's probably going to be some questions or need for additional information, so feel free to reach out to anybody on our Teleflex team. We're always more than happy to help. But with that, I will wish you a great rest of your evening, and I hope to see you all on our next Barrigel webinar.